Good afternoon, everyone. I would like to thank you for coming to the presentation today. I would like to present the first foundation model, Prism CTG, developed specifically for CTG analysis. So, in the field of machine learning for CTG analysis, the data curation process is very unique and it's unlike any other field. Patients undergo CTG multiple times during pregnancy for various indications, and in healthy cases, this usually carry no specific outcome. For the CTG showing fetal distress or pregnancy with adverse outcome, usually only the latest CTG is tied to the outcome, since the condition may not have manifested in the earlier traces yet. So researchers often treat earlier traces as not useful and generally discard them during the creation of their data set. In addition to that, they often apply extra filtering steps such as restriction to specific gestational age and maternal age, further shrinking the data set. This unique data curation process results in training data that is often relatively small for deep learning, which in turn learn a poor representation of what CTG is actually like. As a result, the model created by the dataset lack robustness even on their own tasks and has poor generalizability on other datasets. So the main motivation here is clear, which is to learn a general, robust representation of what CTG is like. So instead of discarding all the CTG, we use this CTG from the entire pregnancy periods, since they often still carry meaningful physiological information. To do this, we utilize a method called pre-training. So what is pre-training? Pre-training is an ML process that happens before conventional training state and is popular in recent years for training large foundation models. They involve no labels and require no outcome to train, and they allow the model to learn by itself, which in the case of CTG, teaching itself to understand the language of CTG by giving them a large amount of data to learn the general structure of the CTG. After pre-training, hopefully it will have a working knowledge of CTG, which will make learning CTG downstream tasks much easier. So pre-training in the field of CTG analysis is nothing new. They are generally split into three categories. The first teach the model to recognize known CTG features. The second type involves training on weak label, such as suspected but not confirmed cases, to nudge the model in the right direction. The third one, train the model on earlier gestational CTG from this different gestational period. Sorry. The goal here is the same. They are all trying to help the model to understand the structure of CTG, and they all suffer from the same problem. They are all predefined tasks and they ignore other clinical context that is useful in learning CTG. And most importantly, they are all still trained on small data set. So to address this, we introduce Prism CTG. In summary, the model takes in raw CTG and code it by extracting features through convolutional layers and a frozen random projection separately. And they combine them into a single embedding before feeding it into a transformer. This forms the backbone of Prism CTG itself. Here, the random projection simply means taking the CTG and transforming it into a higher dimensional space and then quantize it into a single label. Assigning each segment to a general pattern, the model then learns to predict. So, we pre-train the model on three tasks simultaneously. First, we randomly mask portion of the CTG and let the model rebuild its signal, giving it hint about the trace structure through the random projection hint. Second, we make the model learn up to 17 established CTG features. And lastly, we ask it to estimate gestational age, maternal age, and how close the trace is to birth based on the given CTG. So to sharpen the learning process, we give each task its own class token, which allow them to share information through cross-attention. So the class can help one another for training. For example, when reconstructing a masked portion of the traces, knowing the clinical features and patient details help the model reconstruct the signal more accurately. So together, all three tasks encode the necessary information needed to learn a general representation of CTG. A few things to highlight here about the training and the evaluation setup. PRISM CTG is trained over 250,000 hours of CTGs from 50,000 pregnancies, spanning over 3 decades from our own Oxford dataset. The pre-training take around 10 hours to train, and the model take around 5 GB in memories, and it fit mostly into all consumer-grade GPU. So, to evaluate how well the model performed in CTG analysis, we compare the model across 7 tasks with up to 18 models. And the 18 models that we choose contain a mixture of in-domain models and also current state-of-the-art time series models. For each task, we simply assign additional classification layer on top and fine-tune the classification layer only for a specific task. So the goal here is to show that the model is able to learn a general understanding of CTG and is able to handle a variety of tasks. So when we evaluate our model on 4 antepartum tasks, which is the table on the left, it outperformed all current model, including in-domain model such as patch CTG and neural filter net. More interestingly, when the model are evaluated on a constrained data scenario, our model actually gained up to 30% better in performance than in-domain model, and actually require less data to achieve similar performance with models trained on complete or full data. The complete result actually can be found on the paper, which I'll give the link towards the end of the presentation. Additionally, since our model performed well in antepartum tasks, we were curious on how our model will perform on common intrapartum tasks, given that pre-training data contain less than 5% intrapartum data. What we found is that our model worked well in intrapartum tasks on the 2 small data sets that we tested on as well. They also seem to work well with small training data, although the performance gap is smaller than those in antepartum tasks. Interestingly, the model that marginally beat out our PRISM CTG was actually the state-of-the-art model that is used for forecasting, which is our time mixer. So, in conclusion, our result indicate that pre-training on large portion of antepartum CTG seems to transfer well to intrapartum tasks as well. We follow up by asking whether pre-trainings help with generalizability. We choose acidosis classification, which is a popular task in intrapartum field, as the experiment here. So in the experiment, we train our model on one data set and evaluate our model on a separate data set. So we use the popular CTU UHB data set and also the soon-to-be released APHP data set for this experiment. What we found is that they generalize a lot better, especially for CTU UHB data set, which is the figure on the right. And when we compare our model with other study that did similar external validation on the same data set, our model actually achieved comparable performance using significantly less number of recording during training. So we also evaluated the robustness of our model to signal dropout. What we found is that our model is generally more robust compared to all the other supervised model and performs significantly better in severe level of signal dropout. As shown in our analysis earlier, our model has learned a working knowledge of CTG and delivered strong performance. It was done simply by pre-training with the right clinical context. This unit of work is especially helpful for researchers with small label data set And they also seem to handle signal dropout well, which is valuable for intrapartum setting, considering that they tend to have noisier CTG. The model is also relatively cheap to train on and fine-tune, and can be done on most consumer-grade GPU. They also help to open up research question that is niche, where data are often rare or too small to work with. So, however, there are a few limitations to our study. The model was only evaluated on 2 small intrapartum data set, and there were no antepartum external data set for us to test on. Incorporating clinical context is rarely done in this field, which was done for our model. So making comparison with other model and study is actually very difficult. All right, thank you so much. Yeah.
Online and in person. Do you mind sharing with me as well?
Oh, cool. Yeah, this is really exciting, and it makes my job afterwards also a little bit easier, as far as showing that self-supervised learning is, I think, well, if not the way of the future, because it's hard to say, but it's definitely the way to go right now. And what I would like to ask is just a kind of a technical insight, but I think it will be interesting for a lot of people. For those of us who use Macs with the memory basically more than enough, do you think it could easily be done with a unified memory? Because the 5 gig footprint seems to be really inviting.
Yes, it is possible, but the pre-training process will probably take a much longer time, because this was done mainly on 5090, so it takes 10 hours.
On a CUDA,
yeah.
so it would, okay.
Yeah.
I think that maybe finding a way to optimize it for the Mac architecture could maybe open even more the utility.
For sure. Yeah.
Thank you for your presentation, really interesting. You put a lot of effort into the pre-training and less effort into classification, just using linear probing.
Yep.
Is this like a further work to improve the classification task, or do you expect that your pre-training is sufficient for a simple classifier?
So the reason why I chose linear probing was because most of the study in pre-training are done using the same method. But if we do the whole fine-tuning, I expect the model to perform even better. But linear probing actually require even less memory, so it will be easier for everyone to use and cheaper too.
Yes, thank you for the presentation. You said the model is dealing well with imperfect data.
Sorry?
And somewhere at the end, one of the advantages of your model.
Yep.
So imperfections in terms of, let's say, what? Missingness? What are the
So
imperfect?
What we say signal dropout is just missingness.
Just missingness.
Yes.
Ah, right.
I saw there was on one slide showing prediction of abnormal antepartum recordings. I was just wondering what the label was there. Like, what was the label using to say it was an abnormal antepartum recording?
So abnormal is anything for the neonates with adverse outcome. So we kind of like forecast whatever adverse outcome they have.
Excellent. No, thank you.
Any other questions here while I'm... Oh, I do have a question, if I may, just a second. What's your plan, guys, for open sourcing it or opening up the weights, or any plans there?
The weights, I'll have to discuss with my PI.
Sure.
Yeah.
I appreciate it. Thank you. Okay, thank you very much.
Thank you.